The following podcast is part of a certified educational activity titled How I Think, How I Treat Btk Inhibitors as a Centerpiece of Care for Hematologic Cancers. Access the entire activity and complete the post-test at peerview.com/UVJ860. Downloadable slides and practice aids are also available.
Hello, and welcome to our virtual webcast, How I Think, How I Treat Btk Inhibitors as a Centerpiece Care for Hematologic Cancers. My name is Dr. John Bird from The Ohio State University. I'm pleased to welcome my two colleagues, Alexei Danilov and Dr. Nicole Lamana. Before we move on, I'd like to thank the Medical Learning Institute and PVI, Peer Review Institute for Medical Education, for developing this educational event, and to AstraZeneca for providing the educational grant for this webcast. Here is our agenda. We will talk first about the BTK inhibitor class, how they work, and implications across malignant settings. Secondly, we'll talk about their role in the treatment of chronic lymphocytic leukemia. And finally, we'll talk about their use in other B-cell cancers, including mantle cell lymphoma and other diseases such as Waldenstrom's, follicular lymphoma, and large cell lymphoma. Finally, we'll summarize. We will interject throughout this how we apply these agents in our current time as well in this COVID pandemic. So my talk will be on the BTK inhibitor class, how they work, and their role across hematologic malignancies. To talk about BTK inhibitors or Bruton's tyrosine kinase, please don't go online and look up BTK. You'll come up with a lot of bad things as opposed to the good thing that this class of drugs represents for our patients with B-cell malignancies. So this outlines in a very simplistic form. I like to think of things simplistically, of how B cells develop and how they mature and where transformation occurs. And here we have depicted a nice cartoon of bone marrow. And B cells come from a stem cell, and we have immature B cells that have not undergone rearrangement, pre-B cells, and it's often pre-B cells, these pre-B cells that derive very immature types of B-cell malignancies such as ALL or B-cell lymphoblastic lymphoma. As cells mature, they go to the spleen or the lymph nodes and pass through the germinal center where they mature and rearrange. And across this development, we see development of different types of CLL, large cell lymphoma, and more mature B-cell malignancies such as Waldenstrom's, IGVH, mutated CLL, and not shown here, plasma cell and multiple myeloma. Where does the B-cell receptor and BTK fit in this? This sort of depicts two things. We first see the B-cell receptor with likely a high affinity attaching to an antigen and a signal that's generated through the B-cell receptor down to CD79A and B, Syk getting phosphorylated, and this occurring as a signalosome where all those components, Syk, PI3 kinase, coming together in what's called an ITAM. Right beyond that is that our friend BTK, or Bruton's tyrosine kinase, and it sort of sets fairly high in the B-cell receptor signaling pathway and signals downstream to a variety of different things that activate B cells. BTK also serves a very important role not only in the B-cell receptor signaling, but in toll receptor signaling, which occurs, from when B cells see DNA or other things, and that signals through the toll receptor signaling pathway. It's also involved in chemokine and integrin signaling. So really, we see here three different components that BTK plays a significant role. And this is probably why this represents a good target. Ibrutinib not only is important to B cell receptor signaling, but also to integrin signaling and toll receptor signaling. What happens when this gets disrupted? Well, this is of all the signaling components of the B cell receptor signaling pathway, BTK is probably the most selective. And how do we know this? In a mouse model, the XID mouse model, where BTK lacks the kinase component of the protein, the mouse has diminished B cells. It has some very modest other effects in immune effector cells, their NK cells, monocytes, and dendritic cells. But there's actually a polarization of the immune system that we don't clearly understand that's favorable in this mouse. When you knock out BTK completely, where the mouse doesn't have BTK, what you see is a more profound B cell defect, but similar effects in the other lineages. And this is probably because there's compensation with other Tec family kinases in the other cell lineages. Most importantly, there's a disease called X-linked agammaglobulinemia that was described in the 90s to be due to truncating mutations in BTK. And patients with this have an absence of B cells, diminished immunoglobulin, but as long as you replace that, they can live a normal life. And this suggests really that this represents a good target because it's important to B cells in several different areas. But when you take it out, there's not a lot of effect on other organs in the patient's body. Why would we think B cell receptor signaling is a good target in lymphomas that we're going to be talking about today? I sort of summarized several different places that implicate the importance of B cell receptor signaling. The important thing when we look at CLL, which we're talking quite a bit, we see that the B cell receptor we stereotype BCR. We have signaling that can occur even in the absence of an antigen attaching, autonomous signaling. In several of the other large cell lymphoma, in marginal zone lymphoma, we see mutations in components of the B cell receptor signaling. And in Waldenstrom's, we see MYD88 mutations that cause activation. We know in CLL that integrin signaling is very important. And in CLL, we also know toll receptor signaling is very important. And so when we look across the different diseases, the more overlap we have with these different things probably explains why the drugs work the way they do. For instance, in CLL, the B cell receptor signaling, integrin signaling, and MYD88 signaling or toll receptor signaling are all important. Whereas in some of the other malignancies where there's less of a response, one or two of these may be less important. We have several of these, Ibrutinib, Acalabrutinib, and Xanabrutinib. Their approval extends across multiple areas for Ibrutinib, 2 for Acalabrutinib, and 1 currently for Xanabrutinib, tracking very much with how long these BTK inhibitors have been around. When we look at targeting BTK, this is a kinase, and most kinases that were developed up until Ibrutinib were developed as reversible kinase inhibitors. And this is in part due to chemists' concern and biologists' concern that if a target is ubiquitous, you're going to see a lot of toxicity. Similarly, if a drug irreversibly binds to a target, then you could get adduct formation and have an immune response to that. Ibrutinib, though, taught us that BTK first is a good target. And if we can inhibit it very potently, we might see a big effect. And this would afford the opportunity of dosing less frequency and still putting a lot of pressure on the target. It also, if we're attaching a drug irreversibly to a kinase, then we can measure the kinase with a probe. And this really allowed us to know exactly how to dose, which is very different than other drugs that we use, mostly the reversible kinase inhibitors. Ibrutinib was the first BTK inhibitor introduced for CLL that was irreversible. And again, this is a very potent irreversible inhibitor. It worked in dogs. It's a very short half-life, but again, it's irreversible. And the only challenge with it is, as a first-generation medicine, it had other irreversible targets, that are listed here. And it has several irreversible targets as well. And all of these together may offer the potential for side effects. Acalabrutinib was a follower, and it was designed to be a drug, to be a more selective agent. And when we look at the comparison of some of these alternative targets that ibrutinib hits, we see that acalabrutinib is much more selective, and that you can see that in the kinome scan, where you see less red dots that mostly correspond to TEC family members, whereas with ibrutinib you're hitting several other things. Xanabrutinib as well was designed as a second generation molecule and misses some of the alternative kinases of ibrutinib, but probably is a little less selective than acalabrutinib. And again, this is a newer BTK inhibitor, say the third to be approved, but it's going through multiple clinical trials right now. What are the challenges when we inhibit alternative kinases with BTK inhibitors? And some of this we discovered with ibrutinib initially, along with all the patient benefit. We had to learn about bleeding and cardiac toxicity, mainly manifesting as atrial arrhythmias, very rare ventricular arrhythmias, and hypertension. And what all of this is from, we're not certain. A lot of kinase inhibitors cause hypertension. TEC likely contributes to some of the bleeding with ibrutinib. Certainly, EGFR is also hit. We know from the EGFR inhibitors that rash, diarrhea, and arthralgias are quite common. So, what are some strategies that are being taken as the first generation BTK inhibitors have moved forward? A big area of interest are the reversible non-cis41 binding or reversible BTK inhibitors. And unlike ibrutinib or acalabrutinib or Xanabrutinib, when the cis41S site mutates, where you get a cysteine that mutates to a serine, which is about 80% of patients who develop resistance will develop that. Ibrutinib will bind only reversibly. Acalabrutinib doesn't bind at all because it depends upon the pocket. And so coming up with a strategy that doesn't depend upon that binding, and there are several covalent binders that are coming forth. I'm going to talk, there are probably 6 or 7. I'm going to talk about 2 that I think are the most promising. One is the LOXO305 molecule that a lot of investigators have been involved with. Dr. Mato presented a clinical presentation at ASH this past year, and this molecule is very selective. It mainly hits BTK. It has a long half-life, and it's in early clinical trials in CLL patients with cis41S mutations and relapse CLL. Another one is RQL531. It's less selective, but it's reversible, and it binds to BTK probably better, the mutated form, than the wild type form. And it was designed in this fashion. And it hit several other kinases. And Dr. Jennifer Wayak presented at ASH about this. And there's also, because this is a broader BTK inhibitor, there's suggestion that it may have activity, at least modestly, in patients with Richter's transformation as well, likely from some of the alternative kinases. An exciting form, and if we can move this forward to get it to a drug, are the PROTACs. And that PROTAC stands for proteolysis targeting chimeras. And this is a really clever drug approach that Dr. Craig Cruz at Yale and others have developed, where you take you go after a target protein, and there are many that are shown here, including BTK, and you use a reversible drug often. You can use an irreversible drug, but a reversible drug is probably going to be better. And you attach a linker to that, and then a component of a drug that's recruited by E3 ubiquitin ligases. And Ben Ebert's group showed that the lenalidomide, pomalidomide family work this way with Icaros and Ilos. And so this PROTAC works in a similar way. And indeed, there are a lot of publications. Our group has had a publication, this nice paper that was in Blood, published. And this was a unique molecule because it not only recruits recruits IKZF1 and IKZF3 using the backbone of a pomalidomide derivative, but it also recruits BTK. And it promotes degradation. And what you see is that in this lymphoma cell model, that this is working better than lenalidomide, better than ibrutinib, because it's taking both targets and causing them to be degraded. I want to switch in the last couple of minutes to talking about something that we're seeing, unfortunately, a lot of, and probably Dr. Lamanna would be the more appropriate person to talk about this, but I'm going to introduce it, and we'll talk about where COVID fits into our practice of CLL and lymphoma as we go on. COVID, as we know, is a dreadful viral disease caused by the SARS-CoV-2 virus, and it presents with constitutional symptoms, chest X-ray and chest CT abnormalities, and approximately 20% of patients will have serious disease, a good subset requiring intubation. And the death rate from this is 2.5% to 7.2% in Italy. The variety of risk factors, but most importantly, the patients with cancer and with leukemia have a much higher mortality rate, 40% in China, as compared to 8% without cancer of the patients that were hospitalized. The mechanism of pulmonary toxicity is very similar to influenza or pneumococcal pneumonia, and patients have elevated cytokines, pulmonary infiltrates with neutrophils, and in some patients you have microthrombi. Why might Bruton's tyrosine kinase inhibitors be relevant to this? There's multiple papers showing that BTK diminishes lung inflammation caused by sepsis, hemorrhage, and pneumococcal pneumonia. This generally is derived in all of these diseases by macrophages and neutrophils releasing in the lungs, causing inflammation and the diminished ability to oxygenate. A real neat study done by a group in Texas, Dr. Florence and colleagues reported using a fatal influenza challenge and treating mice with ibrutinib inhaled 3 days after the fatal inhalation challenge of influenza A was given. And this shows a survival curve. The mice that got PBS were not healthy, and they all died. Whereas the mice that got ibrutinib inhaled survived. They were sick, as denoted by losing some body weight, but they survived. This group showed very nicely that you see diminished, with the patients getting ibrutinib, you see diminished inflammation in the lungs, and you see increased lung volume capacity. And when you look at all those bad cytokines that you see in people with COVID-19, you see the same ones in these mice getting influenza A, and they're diminished with ibrutinib. So where does this lead us? Clinically, two groups have reported some data on ibrutinib. The first was a study from Janice Gabrieloff's group that looked at 8 CLL patients on ibrutinib who were hospitalized. 2 continued therapy and had mild disease and recovered. 6 stopped therapy. 2 of these died due to ARDS. Again, anecdotal data. Another anecdotal series coming from Dr. Trion showed 6 patients with Waldenstrom's on ibrutinib. 5 were on full dose and had mild cases of COVID and recovered. 1 patient was on a lower dose that had been lower to that dose because of toxicity, and they ultimately went off it. They had a flare of their disease and went on the ventilator, and then were started back on their ibrutinib at 420 milligrams a day, and were able to extubate 2 days later. This anecdotal data, along with the very strong correlative work, preclinical work, fostered a variety of ongoing studies now that are opening, one with Ibrutinib, comparing it to placebo control, one with Acalabrutinib, and one with Xanabrutinib. And these are the three that I can tell you about. There are others, that are opening, that are, they're exciting. And this is really a theme where we're seeing that our CLL medicines and our lymphoma medicines, targeting BTK, may have a potential role in the treatment of COVID-19. The studies, which are, are double-blind, placebo-controlled, need to be done before we know this. So here's the summary of the talk. Clearly, B-cell receptor signaling is important to B-cell survival. BTK plays a very important role in B-cell receptor signaling. Hopefully, you'll come away that irreversible BTK inhibitors are clinically efficacious. Say the different molecules, based upon their selectivity, have different side effects. PROTACs represent an exciting new modality, as do the reversible BTK inhibitors for resistance. And as we move forward understanding more about COVID-19, hopefully these agents will be useful in the treatment of COVID-19. We'll have to see this with the trials. So I'm seeing we have one question from the audience. And somebody's asking how different are the mechanisms of resistance to BTK inhibitors compared to among the different generation of drugs. I'm assuming you're meaning Ibrutinib versus Acalabrutinib versus Xanabrutinib. And the mechanism is pretty much the same. All three of those predominantly develop Cis41S mutations. PLC gamma 2 mutations can rarely occur. And with the new BTK inhibitors, the reversible inhibitors, we don't know yet. So I'm going to move on to the second speaker. And at this point, it's a great honor to introduce Dr. Nicole Lamanna, who is an associate professor and leads the CLL program at New York Presbyterian Columbia University Medical Center. Dr. Lamanna, I really look forward to hearing your talk.
Thank you. So I want to thank the organizers and Dr. Bird for having me come and discuss my thoughts on the BTK inhibitors in the management of CLL. And of course, first, we're going to talk about the first generation, as Dr. Bird had already described. And we're going to talk about Ibrutinib, because Ibrutinib was the first to market, and we have the longest data on Ibrutinib therapy in our CLL patient population. This is a nice update by Dr. Bird and colleagues looking at the initial 1102 study, 8 years now of follow-up of Ibrutinib in a small cohort of treatment naive as well as relapse refractory. And I think this really says a lot. It illustrates how well the efficacy of this class of drug is on patients with CLL. And this is really why CLL patients have done so well and why it really was labeled as a game changer in the treatment management of our patients. You can see here that as in the treatment naive cohort, the median PFS was not reached and the 7-year progression-free survival is 83%. I think this really speaks volumes of how well this agent is for the treatment of our patients. Then, of course, the next logical question became, okay, so now we have this wonderful new agent in CLL treatment, but how does this compare to what we've been traditionally giving to our patients, i.e. chemoimmunotherapy? And so here, there were 2 studies that are obviously well known to many of you. The Alliance study was looking at chemoimmunotherapy with bendamustine and rituximab versus Ibrutinib and Ibrutinib rituximab. And this is in the older patient population, age 65 years of age, untreated. And so this was the common treatment strategy that many of us would initially give to our patients who were older and more frail with comorbidities. You can see here that the results of this study clearly show that the Ibrutinib-based combinations, whether with or without rituximab, the progression-free survival was better than bendamustine and rituximab. So this is one of the first studies showing a randomized study showing the beneficial effects of a BTK inhibitor, i.e. Ibrutinib, over chemoimmunotherapy. And clearly, again, a game changer for many patients, but also for many providers when they saw this data. Now, whether we're going to talk about this more, whether the rituximab or the CD20 monoclonal antibody adds a benefit to a BTK inhibitor, in this case ibrutinib, there was no difference in PFS between the ibrutinib arms on this study, and we'll talk more about this later. For the younger patient population, the other randomized study looking at FCR, so again, another gold standard traditional chemoimmunotherapy program that many of us would give our younger, fitter patients with CLL. So this is FCR versus ibrutinib and rituximab. Unfortunately, unlike the Alliance study, there was not a monotherapy arm with ibrutinib, and so we have ibrutinib rituximab versus FCR. Here you can look at the endpoint PFS, again favoring, you see ibrutinib and rituximab with FCR. There was no difference in overall survival, but again, the PFS strikingly showing again how this BTK inhibitor did well for patients in the frontline setting compared to chemoimmunotherapy. And so this is, this and the Alliance study, I think, are two studies showing very clearly how the pullback from chemoimmunotherapy has been happening over the past several years with the advent of drugs like ibrutinib. I think what's also important about this data that has to be noted is that when you start breaking down patients by their characteristics, their genomic features, I think it's very important to note that for patients who had mutated IgHV, these are the patients that we call good risk. Here's where we still talk about chemoimmunotherapy, because you can see here that patients who received ibrutinib and rituximab or FCR did very well. So both cohorts did well with this type of with either treatment. But when you look at the unmutated IgHV patients, you can see here that chemoimmunotherapy, i.e. FCR in this study, falls short. And so this is, I think, one clear deciding factor when you're talking about patients. If you have a patient with an unmutated IgHV status, many of us will steer those patients away from chemoimmunotherapy based on data like this. The MD Anderson group also showed in their FCR data, when they broke the data down for several hundreds of patients originally treated on their FCR program, that similarly the patients who were IgHV unmutated, their responses, they might have had a good response initially, but their PFS was shorter. And so I think this is yet another piece of data suggesting a move away from chemoimmunotherapy. Now here's another combination. Instead of rituximab, we have obinutuzumab combined with ibrutinib. And so again, illustrating, can BTK inhibition improve the outcome in patients in the mutated IgHV subset? And so again, historically, the unmutated patients do worse, as some of the data alluded to, with chemoimmunotherapy. And can you bring those patients up or make their outcome more favorable as if they were the IgHV mutated? And you can clearly see that those folks who are getting an ibrutinib-based combination, again, there wasn't a ibrutinib monotherapy, but certainly that those unmutated folks in the orange curves do much better. You could see the blue curve for the chlorambucil obinutuzumab unmutated folks did far worse. What about ibrutinib in the relapse refractory CLL population? I think this also, obviously, when ibrutinib first was used in the initial studies, clearly in the relapse refractory population, many of those patients were heavily pretreated, multiple chemoimmunotherapy programs, and would have otherwise died, shortly from their CLL from progression of disease. And when ibrutinib came out, this was a game changer for the relapse refractory patients as well. And so clearly you can see here the PFS for those without and with complex karyotype was different, of course. For the median PFS for those with both complex and deletion 17p, obviously they did not as well. And the median PFS those with complex karyotype without concurrent deletion 17p was more favorable. I think one of the things I like to, when I first saw this curve, from the 1102 data, it really reminded me of 20 years ago, even though this is apples and oranges, but I had to bring this up because when you look at the Donner paper in 2000 and 20 years ago and look at how far we've come, and you break patients down by cytogenetic abnormalities, a patient who is diagnosed with CLL and a 17p deletion, their median survival was a little greater than 3 years. And here's the 1102 data with ibrutinib, and this is relapse refractory data. And even then, again, look at the PFS for patients with a 17p deletion, which is the black curve. So clearly a drug like ibrutinib has extended the survival of patients who 20 years ago had the poorest outcome. And I think that, again, remarks greatly how well these drugs work for our patients. So moving on to the second generation BTK inhibitors in CLL. So as Dr. Bird mentioned, let's talk about Acalabrutinib, which has approval in CLL. More selective. I'm not going to dwell on this. You saw this slide earlier. But again, here is now the treatment naive cohort, now with 53-month follow-up, so over 4 years of follow-up in the treatment-naive population. And look at the PFS curve with Acalabrutinib as monotherapy. I mean, this is really spectacular, showing its true activity, again, very similar to the Ibrutinib curve I showed you earlier. The Elevate data was a phase 3 randomized study looking at Acalabrutinib plus or minus obinutuzumab versus obinutuzumab and chlorambucil in our older patient population, so age 65 years or older, or those who are younger than 65 with coexisting medical problems or a SEER score greater than 6 or poor renal insufficiency. And you can see here that the PFS favors the Acalabrutinib arms. And this is obviously, I don't think this is surprising data given that it was randomized to obinutuzumab and chlorambucil, given the efficacy we saw with ibrutinib monotherapy and knowing the Ibrutinib combination data as well versus chlorambucil. But I think this also highlights the fact that how well the BTK inhibitors, including the second generation, does for our CLL patient population and moving away from true chemoimmunotherapy. Again, here obinutuzumab was added to the Acalabrutinib versus Acalabrutinib monotherapy arm. It is still, there was anti-CD20 not necessarily beneficial, but I think, there are certain circumstances which we can talk about where I might think that actually an anti-CD20 could be beneficial with a BTK inhibitor. In this, you can see here, if you broke down the PFS by subgroups, regardless of the subgroup type, if they have deletion 17p, if they were unmutated or complex karyotypes, you can see that, again, the high-risk patients also benefit from Acalabrutinib-based therapy versus obinutuzumab chlorambucil. Now, obviously, John alluded to talking about some of the issues that occur with BTK inhibitors and some of the side effects, and we're going to talk about them as well. So when we look at intolerance to a BTK inhibitor such as ibrutinib, it became apparent from the initial clinical trial data that when we looked at real-world data, so many centers got together and looked at their patients on ibrutinib, and there was issues that there were toxicities that were higher than what was initially reported on the clinical trials. And I think that often is the case particularly from some of our initial clinical trial data, and then with more experience across the country, varying supportive care, a whole bunch of other reasons that we can bring into it. Oftentimes, we'll see different increase in toxicity or other issues that could emerge with longer follow-up. And so here you see whether the patient, whether they received ibrutinib in frontline or whether they received ibrutinib in relapse. The reason for discontinuation was more so due to toxicity, greater than 50%, rather than CLL progression. And so I do think that as well as exciting and obviously as game-changing as this class of agents is, certainly we have to figure out better ways to manage the side effects, help our patients get through that, or to stay on therapy for various reasons. And obviously we'll talk about time-limited durations of therapies as well. So this study, the CL208, Acalabrutinib study, looked at patients who were ibrutinib intolerant, small subset of patients. There were 33 patients, but they re-challenged the patients on Acalabrutinib, and you can see that 72% of those patients did not have a reoccurrence of their ibrutinib-related adverse event, whereas 28% did, some at same or lower grade. Only 3% had higher grade. So certainly, I think if your patient is benefiting from ibrutinib, then has an adverse event, but is otherwise, from an efficacious standpoint, doing well on a BTK inhibitor, could one choose to go on to Acalabrutinib to see? Absolutely. I think that's certainly an option for our patients. What about Acalabrutinib in relapse? You can see here that in the relapse refractory setting, patients who had median number of 3 prior regimens, advanced stage disease, also did well from a PFS standpoint. at a 42.5-month follow-up. Again, patients with high-risk features also, again, benefited from Acalabrutinib in this relapse refractory setting. And I think these numbers are very akin to the Ibrutinib data, and yet showing that Acalabrutinib, certainly I do not think from an efficacious standpoint that there's a difference. I mean, obviously we're going to be waiting the head-to-head data, but certainly Acalabrutinib is very efficacious in our patient population and doesn't appear to be different in that case. Now, what about when we look at, at the time before these, obviously, venetoclax approved, also the other drug that was approved in relapse refractory CLL patients was the PI3 kinase idelalisib. And so this was a phase 3 study, the Ascend study, that looked at, in relapse refractory CLL patients, that looked at Acalabrutinib versus idelalisib, rituximab versus bendamustine rituximab. And similarly that, again, with patients received chemoimmunotherapy at that time as their frontline treatment, then in relapse, they often went to Ibrutinib or a BTK inhibitor, or idelalisib rituximab or bendamustine rituximab. And so these were all common regimens used in the relapse refractory setting. And so here was a randomized study looking at those combinations. And you can see here that the PFS favored Acalabrutinib over bendamustine rituximab or over idelalisib and rituximab. And again, this is in the relapse refractory setting, but again showing the benefit of a BTK inhibitor over chemoimmunotherapy. And then even so, when you talk about the PI3 kinase inhibitors, clearly it favored the BTK inhibitor over the PI3 combination. If you look at patients with deletion 17p or IGHV subgroups, again, it looks like the data favors Acalabrutinib even over idelalisib rituximab or bendamustine and rituximab. And I think this is consistent across all subgroups of patients favoring Acalabrutinib. So I think this data, when you evaluate the Ascend study, I think many of us looked at this, that certainly our patients should have exposure to a BTK inhibitor, at least before a PI3 kinase inhibitor, at least based on this randomized data. Obviously, there are other studies looking at PI3 kinase inhibitors and combinations, but certainly given this, I think that we would favor using a BTK inhibitor first. Now, as John mentioned, there's obviously another second-generation BTK inhibitor in CLL. This is not yet FDA approved for CLL, but for relapse mantle cell lymphoma, and that is Xanabrutinib. So there's many clinical trials with Xanabrutinib that are currently ongoing, so I just wanted to highlight a few. This is the Sequoia study. This is a study of treatment-naive patients with deletion 17p. And they were treated with Xanabrutinib at 160 milligrams twice daily. And you can see here, I mean, the duration of response is short, but the overall response is very good. And obviously this data will need to be followed. Xanabrutinib is a twice daily drug, as is Acalabrutinib. Ibrutinib is the once daily dosing, just to keep that in mind. Another study looking at Xanabrutinib in relapse refractory CLL, again, in this patient cohort, a high overall response. And you can see that certainly this shows similar efficacy, at least, again, more immature data compared to Acalabrutinib, but shows very similar efficacy to what we're seeing with the other BTK inhibitors. And there's also a Xanabrutinib for intolerant patients, for BTK intolerant patients, similar to what I noted earlier about the Acalabrutinib intolerant study. And there's a Xanabrutinib versus Ibrutinib in patients with relapse refractory CLL that is ongoing. So what about the safety experience with BTK inhibitors in CLL? So as we alluded to earlier, the fact that some of these BTK inhibitors affect other signals and TEC and EGFR can be responsible for some of the adverse events that we see and that we noted initially with Ibrutinib being the first to market. And many of these side effects, there are many of our patients on Ibrutinib who tolerate Ibrutinib very, very well. And then there are those that obviously don't. And there's many of the side effects are more prominent in the first year of therapy and wane over time. Susan O'Brien had updated that data again from the initial 1102, showing that many of the side effects declined over time. But there are some that seem to be persistent. So hypertension, I think upper respiratory tract infections, i.e. pneumonia, are still prevalent, cardiac arrhythmias. So these are some of the side effects that we saw with ibrutinib that are apparent. Here is some of the adverse events with acalabrutinib, and similarly, although possibly the percentage is different compared to ibrutinib without head-to-head, but most of the side effects that occurred with acalabrutinib really do occur within the first year and then decline in subsequent years. I think the difference with acalabrutinib that we've talked about that many of you may be aware of is the incidence of headache. So headaches are more common with acalabrutinib than ibrutinib, but usually, again, very self-limiting and usually not a reason for discontinuation of therapy, usually mild and abates with time. I think if you look at this curve, the hypertension, however, is still apparent, and so I think that's something to keep an eye on with acalabrutinib as well. But if you look at events of clinical interest, so when you talk about atrial or cardiac events, atrial fibrillation, hemorrhage, hypertension, at least for all grades and grade greater than 3, at least from this data cohort, it seems that the frequency is less compared to the ibrutinib studies. But again, there is a head-to-head study that is closed to accrual, acalabrutinib versus ibrutinib, in the relapse refractory high-risk patient population. And so we're waiting to see that data to see if the frequency of adverse events is different based on what we know about acalabrutinib as opposed to ibrutinib. So are BTK combinations in the future? And obviously, we know that there is already one combination that was approved for frontline treatment of CLL, which is not a BTK combination. It's venetoclax and obinutuzumab. But what about BTK combinations? And there are many that are being studied currently in clinical development, but I'm just going to highlight one or two. The Captivate data is the combination of ibrutinib and venetoclax. So obviously 2 oral agents, very desirable because they're both oral. And so this is data in about 164 treatment-naive patients who received ibrutinib first for the first 3 cycles, followed by venetoclax ramp-up that was added in until patients achieved 400 milligrams daily dosing, and then patients received the combination therapy for 12 cycles, so approximately 15 cycles of therapy following peripheral blood and bone marrow MRD levels. And obviously, you can see that there's a high rate of undetectable MRD achieved in both the peripheral blood and bone marrow with up to 12 cycles. So this is obviously an exciting combination. And obviously, people are looking forward to more long-term data with this 2 oral ibrutinib venetoclax-based combination. And I'll touch more about that in a little while. And then we have another triplet, or I should say that was a doublet. So let's talk about triplets. So what about looking at a BTK inhibitor, acalabrutinib in this case, with venetoclax, a BCL2 inhibitor, and a monoclonal antibody, obinutuzumab, so AVO for initial therapy. And here there's a 28-day cycle lead-in with acalabrutinib, and then followed by 6 cycles of obinutuzumab, and venetoclax is added in at cycle 4. They have combination treatment, and at cycle 15, they have their first bone marrow disease assessment. If they are MRD negative, they can stop therapy. If they still have disease or MRD positive, can go on continuing acalabrutinib and venetoclax until cycle 24, and they have another reevaluation. Similarly, if they are bone marrow, if they are negative, they can come off therapy. Otherwise, they can continue therapy until they have either toxicity or progression of disease. And you can see here that, again, there is a high rate of bone marrow and peripheral blood MRD negativity with these combinations. So I think that there's obviously, given that we started out with the BTK inhibitors being monotherapy, chronic continuous therapy. And now we're exploring doublets and triplets with BTK inhibitors and combinations to look at deeper remissions and whether we could do time-limited durations of therapies or truncate therapies. This is obviously a very fervent area of clinical research that we need some follow-up and long-term data. And I'll talk about that a little bit in the for the future. So what about areas of unmet need? And I think Richter's transformation is one of those areas. We've done phenomenal, as I showed you those curves earlier, for patients with 17p who notoriously had a poor overall survival and did horribly with chemoimmunotherapy. And now the survival rates have drastically improved with our patients with 17p. I think Richter's transformation is still an area that we do poorly with, and we have not had many good options of therapy for these patients. This is a publication by Dr. Woyak and colleagues looking at patients who had discontinued Ibrutinib and learned more about those patients, including mechanisms of resistance. Now, caveat here is that these patients were part of some of the initial studies of Ibrutinib, and for four of the studies. And so most of these were relapse refractory patients, i.e. these were patients who had chemoimmunotherapy programs and then got onto one of the initial Ibrutinib studies. And so this was a heavily pretreated group. Regardless of such, not surprisingly, many of these patients were eventually going to lose their response to Ibrutinib. And how could we learn about those individuals? And you can see that at year 2, 3, and 4, you could see the CLL, cumulative incidence of CLL progression. You could see transformation, and typically, I think transformation is probably underreported because we don't always get lymph node biopsies or have confirmation pathologically from tissues. But you could see here the incidence from 7 to 10%. So not unexpected or not what we've seen different from the literature, anywhere from 5 to 15%. But when you look at those players, risk factors for Richter's transformation, I think there are several things that are notable. So one is Notch mutations, complex karyotype, stereotyped BCR. I think there are high-risk features of our patients who make them there are certainly notable features that make them at a higher risk for Richter's transformation. And typically, when we think about therapy for patients with Richter's, we traditionally give them lymphoma-based chemotherapy, either R-CHOP or R-EPOCH, and really these therapies are terrible. There's poor efficacies in our Richter's transformation patients, and I am an advocate that all these patients should be certainly on clinical trials. Because I think that given the fact that these are a rarity of individuals, we really need multi-center clinical trials to find better therapies together for these patients, and we shouldn't have to relegate them to give them R-EPOCH or R-CHOP as their frontline therapy to then get some experimental therapy, given how poor the median PFS and overall survival of these patients is with traditional chemoimmunotherapy such as R-EPOCH or R-CHOP. So one of the, a few years ago, presentation looking at PD-1 inhibitors, so in this case it is pembrolizumab in patients with relapse and transformed CLL patients, and 9 patients with Richter's transformation. There were objective responses in 4 out of the 9, some of them with stable disease for quite some period of time. And so I think that you're going to see several clinical trials looking at combinations of novel agents with PD-1 or PD-L1 inhibitors for our Richter's transformation patients, or PD-1 inhibitors and chemotherapy. So hopefully we'll start really looking at this patient population because oftentimes they're extremely difficult to salvage. We would often give chemoimmunotherapy and try to get those people to allogeneic stem cell transplant. Now we're looking at CAR T cells. And so hopefully we'll make some headway with our patients who unfortunately develop Richter's transformation. So let's talk about practical thoughts and how I think and how I treat on managing CLL with BTK inhibitors. So just to show you this, here is the NCCN guidelines for treatment-naive CLL in 2020. And so for frail patients or for patients who are greater than 65 and not frail, but younger patients with significant comorbidities, you could see the preferred regimens now include Ibrutinib, Acalabrutinib plus or minus obinutuzumab, venetoclax, and obinutuzumab. And for patients less than 65 without significant comorbidities, the same preferred regimens. So you can see chemoimmunotherapy is other recommended regimens, but you could see a strong support of BTK inhibitors and novel agents such as venetoclax. And in the relapse refractory NCCN guidelines, very similarly, again, Acalabrutinib and Ibrutinib, venetoclax and rituximab a la Murano, duvelisib, idelalisib plus rituximab. And similarly for the less than 65 without significant comorbidities, the same preferred regimens. And again, chemoimmunotherapy being relegated further down the line. So BTK inhibitors in the CLL context, I think that they obviously, I've showed you data of how well this class of drug has worked for our patients with CLL, whether as continuous therapies or in combination. They're really a mainstay of treatment, both in our treatment naive and our relapse refractory population. What about the use of continuous oral therapy with a BTK? Clearly, the longer term results have shown that Acalabrutinib, Ibrutinib, long-term has been, relatively safe. There are some side effects that we talked about earlier, but very effective. Whether or not continuous oral therapy with a BTK inhibitor versus a doublet or a triplet, or whether they should be sequential, is sequential therapy better? I think these are, obviously the area of clinical trial interest now. We're trying to gain knowledge about, obviously many patients would like not to have to take a continuous oral therapy for the rest of their life and be on a short or a time-limited duration of therapy and stop. I think that these are obviously strategies that we need longer term follow-up on. We saw the data. I think doublets and triplets, you see a high frequency of response with great MRD negativity with the more aggressive combinations. How that will translate long term or whether a sequential strategy is better, I think we just need longer follow-up to know those. I think that there may be, perhaps we'll learn that certain subtypes of patients may benefit more from a doublet or a triplet, perhaps high-risk individuals with complex karyotype or 17p. Maybe those are the individuals that we might employ a doublet or a triplet, or maybe not, and everybody would benefit from this. Certainly there's a little bit more side effects up front, but may translate into then time off treatment, decreased side effects long-term if they're off therapy, decreased financial cost. But certainly I think we need to know what and how will that change resistant patterns if we're using two orals together. Will that change resistant patterns? There's a lot I think we don't yet know about whether doublet, triplet, sequential might be the best approach. And there may not be one answer each patient. There may not be a one-size-fit-all just yet. What about choosing different amongst the different BTK options? We heard about Acalabrutinib, Ibrutinib, and Xanabrutinib. At least from the data that we have, the second generation BTK inhibitors do appear to be more tolerable. I think the head-to-head trials, such as the Elevate trial, will inform us more about, the direct comparisons. Certainly, if a patient of mine is on Ibrutinib and doing well, I'm not going to switch them to Acalabrutinib or Xanabrutinib if they otherwise are doing fine. However, if I'm going to be starting a new patient on a BTKI, I might think about starting them on a second generation BTKI. And certainly you might sub-select based on other comorbidities, the cardiac issues or so on and so forth. So I think those are all reasons or ways that you can think about the differences of the second generation BTK inhibitors. And I think for high-risk patients, I think this is a no-brainer. I think that for patients who have a deletion 17p, p53, complex karyotypes, I think the use of the BTK inhibitors should be standard of care. We would not think about chemoimmunotherapy in these individuals at all. I think venetoclax certainly is another option, but when we're talking about high-risk individuals, certainly I think we have the longest, more mature data with the BTKIs. Again, we'll have to see whether about combination strategies, whether or not truncated therapy in these higher risk patient population is something we want to do versus not, because many of them will still relapse eventually. Whether continued therapy in that group of patients will be a benefit, we need longer follow up. And then your younger patients, which I talked about earlier, which was maybe the younger, fitter patients who have more favorable disease, who are mutated, 13q deletion, where you still might discuss chemoimmunotherapy. Certainly, I think it's certainly a discussion, but with all the different options available and the fabulous results that we do see with BTK inhibitors, whether it be monotherapy or in combination, certainly, I think you'll see less patients opting for true chemoimmunotherapy alone. I think that being said, I will end there.
Dr. Lamanna, I really want to thank you for that great talk. And I see a couple of questions are coming from the audience. The first is about the use of CD20 antibodies with BTK inhibitors. Is this something that you do?
Yeah, absolutely. I think that's a great question. I mean, I think the studies that I showed earlier don't necessarily support the addition of a BTK inhibitor with a CD20 antibody. However, I do think that there are circumstances where that could be beneficial. There are some of our CLL patients in the face of progressive disease present with autoimmune hemolytic anemia or autoimmune thrombocytopenia. Oftentimes, I'll actually front load those individuals with a CD20 antibody to calm down their autoimmune process, and then add a BTK inhibitor later when things have settled down. So I do think that that it's not completely off the table to use a CD20 monoclonal antibody with a BTK inhibitor. It's just that the data that we've seen so far doesn't necessarily suggest that there's long-term benefit. Although there are other studies from the UK and some other groups who, for patients who were on Ibrutinib for a while, and to enhance their response, obinutuzumab was added later. I mean, I think to deepen their response. Now, whether or not that long-term translates into better PFS or overall survival, I think remains to be seen. So there's not a clear-cut answer that adding a on the whole, I typically don't add a CD20 monoclonal antibody, but sometimes I do find it useful, as I alluded to.
So somebody here has asked a question that I was going to ask you before we started, or after, so I'm going to ask it. So the question is, they have a patient with CLL that is exposed to COVID-19 and is on Ibrutinib. How are you managing these patients?
Yeah, being here in New York, I have to say it was extreme. So, if they're, by all intents and purposes, if they're on therapy, I try to continue, although I have to say that hasn't been all of the patients, because some of them presented in extremis and literally landed, so sick in the ED that they were intubated emergently right away. And they were on a BTK inhibitor. And if they didn't bring their drug and the family couldn't come, we weren't getting their drug. So that they were off of therapy. So some of the patients continued therapy, and some of them were not on therapy during their COVID experience.
But you generally continued it if they could take it.
If they could take it, correct.
Yeah. No. All right. Well, this is great. Thank you for the great talk. We will move on, and then we'll take any other questions at the end. So our third speaker today, who's going to talk about the wider use of BTK inhibitors across lymphoid diseases and where we're going to be going, is somebody I've admired for a long time, Dr. Alexey Danilov, who recently transitioned to the City of Hope National Medical Center, where he's a professor and leads the CLL and lymphoma program. So, Dr. Danilov.
Thank you very much, Dr. Bird, for this introduction. It's a great pleasure to be part of this group of my respected colleagues. And We talked about CLL, but the use of BTK inhibitors is very important in other lymphoid cancers as well, and this is what I'm going to talk about today. And of course, most of the progress in lymphoid cancers so far has been made in mantle cell lymphoma. So mantle cell lymphoma is a lymphoid cancer which originates initially in pre-B cell, where cyclin D1 translocation occurs. And then once this cell enters the germinal center, mutations in the IgHV occur. And if that happens, then a leukemic non-nodal mantle cell lymphoma develops. And this is a less common subtype of mantle cell lymphoma. It's typically characterized by features clinically, which clinically resemble chronic lymphocytic leukemia. So there is involvement of the peripheral blood, bone marrow, and splenomegaly, and essentially rarely no lymphadenopathy. Typically, those patients follow an indolent clinical course, and overall, this probably represents about 10% of our patients with mantle cell lymphoma. However, if the cell bypasses the germinal center, then mantle cell lymphoma cell does not carry IgHV mutations, so it has unmutated IgHV, and like in CLL, this portends poor prognosis. In that case, we have something which is called classical mantle cell lymphoma. And within those, we also have more aggressive MCL variants, which are defined morphologically, such as blastoid and pleomorphic. So between those two types, there is also a difference in frequency of genomic events. For example, ATM mutations almost exclusively occur in classical mantle cell lymphoma with a frequency of 50–60%. And cyclin D1 mutations predominantly occur in leukemic non-nodal subtype. So this is an overall overview of mantle cell lymphoma and its biology. And so far, to this day, upfront therapy of mantle cell lymphoma relies on chemoimmunotherapy combinations. So for patients who are fit, in good shape, and are candidates for high-dose stem cell transplant, the preferred regimens would be basically, pick your favorite. That could be RDHAP or a Nordic regimen, or hypocivad in combination with rituximab, or alternation of R-CHOP or RDHAP. And if patient is not fit and may not undergo intensive chemoimmunotherapy, then preferred regimens could be bendamustine rituximab, VRCAP, or lenalidomide rituximab. Those are the top three, and probably BR is the most commonly used. So far, at least according to NCCN guidelines, there is no role for BTK inhibitors in the management of mantle cell lymphoma in frontline setting. However, there is now very much a role for them in second-line therapy. The problem with mantle cell lymphoma is once it recurs, and again, like CLL, it's incurable disease, save for allogeneic stem cell transplant. Once it recurs, it responds poorly to subsequent lines of chemoimmunotherapy. Overall progression-free survival to those lines will be between 8 and 16 months, and it becomes the combination of the same drugs. So we quickly run out of options. So therefore, preferred regimens in relapsed refractory mantle cell lymphoma become BTK inhibitors, Acalabrutinib, Ibrutinib, Xanabrutinib, as well as some other novel agents, which include lenalidomide or venetoclax, where the data, particularly the latter one, is emerging. So again, you see now that BTK inhibitors stand in the front and center in MCL. So how about other lymphomas? So Ibrutinib has also been approved in therapy of lymphoplasmacytic lymphoma or Waldenstrom macroglobulinemia. It also has accelerated approval in marginal zone lymphoma. Acalabrutinib does have approval in mantle cell lymphoma, so does Xanabrutinib both in relapsed refractory cases. I'm gonna talk a little bit about this, how those different inhibitors behave pharmacokinetically. So you can see Acalabrutinib quickly reaches a peak plasma concentration and then disappears from the blood. So it's dosed twice daily. Ibrutinib is dosed once daily, less of a peak, but much more protracted curve. And Xanabrutinib is sort of a combination of the two, a higher peak, but still a fairly protracted curve, a fairly high AUC. So it's interesting. Again, Acalabrutinib is dosed twice daily, Ibrutinib once daily, and Xanabrutinib has both variants of dosing, both twice daily or once daily in its label. So the progress in MCL studied with Ibrutinib. This was based on a phase 2 study of 111 patients with relapsed refractory MCL who received Ibrutinib at this dose of 560 milligram. So again, to note in lymphoma, the doses for Ibrutinib are slightly different than in CLL, and I'll highlight it over the course of this talk. So those were very, very much pretreated patients with a median of 3 prior therapies. Some received 5 prior therapies. And Ibrutinib was very effective in this heavily pretreated patient population with an overall response rate of 67% and 23% complete response rate by Nccn criteria. Median PFS was about 13 months, and median duration of response was 17.5 months. So the pooled analysis was performed subsequently and found that some patients, particularly those who achieved complete responses, actually could experience a plateau in the curve and stay on the drug for a long time, with remissions lasting longer than 5 years. So for a subset of MCL patients, this is certainly possible. So who could those patients be? If you look at this slide and progression-free survival, for patients who received 1 prior therapy, median PFS is 25 months for Ibrutinib. By contrast, if patients received more than 1 prior therapy, so 2 or more, PFS is significantly shorter. And same for overall survival. The problem is once we run out of chemo options and then BTK inhibition no longer works, then we really do not have many options for those patients, and survival becomes shorter. So this is one of the tantalizing statements to make, that Ibrutinib probably should be used earlier following relapse after chemoimmunotherapy in mantle cell lymphoma. So how about combinations of Ibrutinib and mantle cell lymphoma? So this is the AIM study, which combined venetoclax, here shown under its old name, ABT199, and Ibrutinib in MCL. Patients studied with Ibrutinib, received it for 8 weeks, and then underwent a dose ramp-up of venetoclax. The primary endpoint was complete response rate at 16 weeks of therapy. So at that point, patients received 16 weeks of Ibrutinib and 8 weeks of venetoclax. It's interesting, and it's important to note that initially the study started with a dose of 50 milligram venetoclax. However, 2 patients experienced tumor lysis syndrome, and therefore the ramp-up dosing was subsequently revised, where patients began ramp-up with 20 milligrams. So just like patients with CLL, patients with mantle cell lymphoma can experience tumor lysis syndrome on venetoclax, and Ibrutinib does not necessarily protect from that, at least based on this study, although this is a small study. The other difference here is that ABT199 was escalated up to 800 milligrams based on some additional data. So some of the patients went all the way up to 800 milligrams of venetoclax. And Ibrutinib was again administered at 560 milligram daily. So both drugs here continued until progression. So venetoclax wasn't stopped. It was not a time-limited therapy. But at 16 weeks, this is the data that we had that was published. CR rate was 63% by Lugana, which included PET-CT, and 42% by Nccn criteria, which included CT scans, if you only looked at CT scans. Plus, there were additional partial responses. So overall, response rate was 71%, again with CR rate of over 60%. This trial also included some patients with TP53 aberrations. And those patients, half of them achieved CR, which is really remarkable. We know that patients with P53 aberrations do not respond well to chemoimmunotherapy, and that's true of both CLL and mantle cell lymphoma. And it's really remarkable that those patients had such responses on this study. This is a 3-year update. Again, a small number of patients, which is evident from these curves. They're pretty choppy for those 24 patients, but so far, very remarkable data with median overall survival so far really not reached, because the curve becomes really unstable towards the end. How about other BTK inhibitors in mantle cell lymphoma? Both of my colleagues have presented this slide on selective BTK inhibitor Acalabrutinib, so I won't repeat this too much. Approval of Acalabrutinib in relapsed refractory mantle cell lymphoma was based on a phase 2 study of 124 patients with this disease. Again, older patient population with median age of 68 years. They received 2 prior therapies, in contrast to Ibrutinib study where median of 3 prior therapies was administered. Overall response rate was 80%, with 40% of patients attaining a complete response. So those numbers are a little bit higher than what you see with Ibrutinib data. However, there are 2 key differences. One is that there is 1 less prior therapy, and also those patients were evaluated by Lugano criteria, so using PET-CT. And just like you saw in the AIM data just now, there is some difference which could account for, which can be accounted for. So if we look at the progression-free survival and overall survival data, the median PFS was 19.5 months. So a little bit high with Ibrutinib, but again with the disclosure that patients were a little less heavily pretreated. And at 24 months, overall survival rate was 72%. Again, it's maybe a bit too early to say whether there is a plateau, but overall, those curves to me look fairly similar to what we see with Ibrutinib. So at the very least, I would say that Acalabrutinib is just as effective as Ibrutinib in relapsed refractory mantle cell lymphoma. So what about toxicities? Dr. Lamana mentioned a plethora of toxicities with BTK inhibitors and how this can sometimes be a problem. And she also went over potential differences between Acalabrutinib and Ibrutinib. So this is what happened on this study. Headache was one of the toxicities, and 34% of any grade headache with Acalabrutinib. This is something which is a bit different from what we experience with Ibrutinib, and I recommend all of my patients who take Acalabrutinib to drink coffee, because caffeine seems to help ameliorate headaches. I also, in my experience, I find that if they do happen, they happen early on and then get better with time. There was some diarrhea, very little grade 3. There was some infections with grade 3 only in less than 10% of patients. And some of the typical events associated with BTK inhibitors, including bleeding events, no atrial fibrillation, and really not much rash. Another drug which has been mentioned earlier is Xanabrutinib, which is the newest kid on the block. There were 2 studies of Xanabrutinib in relapsed refractory mantle cell lymphoma, which really enrolled different patient population. So slightly different results in terms of depth of response, but in both studies, overall response rate was over 80%. And duration of response was similar to Acalabrutinib, 18-19 months. So those are the curves right here. Efficacy of Xanabrutinib in relapsed refractory mantle cell lymphoma. And median progression-free survival was 19.2 months, which is similar to the data that we see with Acalabrutinib. So it appears that this new agent also have efficacy similar to other Bruton tyrosine kinase inhibitors. In terms of safety, it's interesting that this drug was associated with about 42% of decreased neutrophil count. This was one of the most common adverse events. There was 33% rash, upper respiratory tract infections, which we are pretty used to see in patients with lymphoid malignancies, and diarrhea at 15%. 26 patients, which is about a quarter, discontinued treatment, and 16 of them due to progressive disease, and 10 due to treatment emergent adverse events. So discontinuation due to adverse events was pretty low. What about moving this to frontline? So AIM study that I showed you earlier, which combined venetoclax and Ibrutinib, did have some previously untreated patients with mantle cell lymphoma. This is another study which is still ongoing and has been reported recently, where Ibrutinib and Rituximab was used in frontline therapy of elderly patients with mantle cell lymphoma. And so far, the results look very promising. And I believe soon we will be seeing more of these studies and the results, potentially thinking of taking those regimens to frontline therapy of mantle cell lymphoma, just like we do in CLL. There are a couple of studies ongoing now with the goal of incorporating BTK inhibitors and chemoimmunotherapy programs in newly diagnosed MCL. You are aware of the SHINE study, which randomizes patients to bendamustine and rituximab with Ibrutinib or not. And this is a phase 3 study which randomizes patients to Acalabrutinib in combination with bendamustine and rituximab or BR alone. The results are not available yet, and it would be really interesting to see how those patients do, where they receive 6 cycles of BR followed by a BTK inhibitor until progression. I want to also briefly mention the role of BTK inhibitors in other cancers. We have been using Ibrutinib in Waldenstrom macroglobulinemia or lymphoplasmacytic lymphoma for some time now. It's approved in both previously untreated and relapsed refractory disease. And INNOVATE study was recently published, which randomized patients to Ibrutinib in combination with rituximab or rituximab alone in those patients. The data was quite impressive. The progression-free survival was significantly improved in patients who received Ibrutinib and rituximab, and PFS was not reached in patients who received BTK inhibitors. However, it was only 20 months in patients who received placebo and rituximab. Overall response rate was very high, 90%, only 47% in patients who received rituximab alone. And overall, a very effective regimen in patients with lymphoplasmacytic lymphoma. Similarly, Acalabrutinib has been studied in patients with LPL, Waldenstrom macroglobulinemia, and very impressive curves as well, both in treatment-naive patients and in patients with refractory relapsed Waldenstrom macroglobulinemia. There is also an important point to make about MYD88 mutations in those patients. So initially it was suggested that patients who have wild-type MYD88 may not respond as well. On the INNOVATE study, those patients actually achieved similar responses, but we don't know yet if those patients will have inferior progression-free survival or overall survival compared to patients with mutated MYD88. A randomized phase 3 study of Xanabrutinib versus Ibrutinib in patients with Waldenstrom macroglobulinemia was recently reported at ASCO. This study randomized patients with MYD88 mutated Waldenstrom macroglobulinemia to those two novel agents. So essentially, this is one of the first studies which compared novel second-generation BTK inhibitor with Ibrutinib. In addition, there was a cohort of patients with wild-type MYD88 who had LPL who simply received Xanabrutinib on arm C. And although there was not a statistically significant difference, Xanabrutinib was associated with a slightly higher CR and VG, very good PR rate, and demonstrated some clinically meaningful advantages in safety and tolerability compared to Ibrutinib. So interestingly, there was lower incidence of atrial fibrillation over a follow-up of 19 months. There was somewhat higher rate of neutropenia in patients who received Xanabrutinib. However, the frequency of infections was actually the same. Also, there was higher frequency of hypertension in patients who received Ibrutinib at 17% compared to 10% among patients who received Xanabrutinib. So very interesting data, and one of the first studies reported this direct comparison. In follicular lymphoma overall, BTK inhibitors so far have been disappointing in terms of efficacy. And in my clinical practice, I do not use BTK inhibitors outside of clinical trials in patients with this disease or when we really run out of options. So if you look at the middle chart, this basically looks at best responses in patients with follicular lymphoma who receive Ibrutinib, and notice that the y-axis is actually in single digits there, so very few responses, and it seems that they may actually depend on the mutational status, where patients with wild-type CARD11 have slightly higher responses than patients with mutated CARD11. This is also confirmed on the right chart, which shows progression-free survival on Ibrutinib for those patients. But overall, with an overall response rate of 20% or so in patients with relapsed follicular lymphoma, this is a slightly inferior option compared to PI3K inhibitors that were mentioned before by Dr. Lamana, or lenalidomide and others. I also will not dwell on diffuse large B-cell lymphoma. In DLBCL being highly heterogeneous disease, the mutational landscape is very diverse, and we are still figuring out who and how responds to BTK inhibitors in that disease. However, I do want to mention BTK inhibitors and their role in CNS lymphoma. And Ibrutinib is by far the most advanced agent there. And this is, of course, the disease which is not only not curable, we really don't have that many options in this disease where we have problems with drug penetration into CNS. And this study was published a couple of years ago, where 20 patients with relapsed refractory CNS lymphoma, either primary or secondary, received Ibrutinib escalated up to 840 milligram. And 17 patients were treated at this MTD, and Ibrutinib was detected in CSF. And here are the responses, and we see that several patients actually achieved complete response. Those patients had MYD88 mutations. Some patients who had CARD11 mutation also, or CD79B mutations also have had partial response, so achieved responses, and some patients stayed on the drug at the time of the publication. And since there were additional combinations of Ibrutinib explored, for example, with methotrexate, which show efficacy of this drug in CNS lymphoma, so something important to think about. So how do I overall think of managing mantle cell lymphoma with Bruton tyrosine kinase inhibitors? Well, so now we really have three options, and it's a rare disease, so it's good to have three options for this type of lymphoma. Dosing is slightly different, as I mentioned before, between those three drugs. In terms of using them in relapsed disease, overall, my inclination is to use them earlier rather than later. Well, the exception being, of course, if a patient experienced a really prolonged response to initial chemoimmunotherapy, and for example, 10, 12 years later, they present with a relapse, bendamustine and rituximab may be an option to consider at that point. However, most patients actually relapse 3-4 years after the initial treatment with chemoimmunotherapy and do not respond well to subsequent CIT. And therefore, for the majority of patients with relapsed disease, I believe BTK inhibitors become very good options, a very good option. Particularly in patients with TP53 aberrations. So those patients really don't respond well to initial chemoimmunotherapy. And I think those patients, once you identify them, it is very important to switch them to BTK inhibitors early. Same applies to patients with complex karyotype. So I have to say in all of my patients with mantle cell lymphoma, not only I try to do FISH cytogenetics for P53 and conventional cytogenetics, but also I do try to submit next generation sequencing to look for P53 mutations, Notch mutations, et cetera, et cetera. Again, just like in CLL, decision to use BTK inhibitors is often determined by patients' comorbidities. There is risk of bleeding, like Dr. Lamanna talked about, particularly in patients who have concurrent anticoagulation. That sometimes makes us uncomfortable. There are cardiovascular events. There is risk of infections, of course, which doesn't completely go away, although it's not nearly as high as with chemoimmunotherapy. And a lot of this work that I mentioned was done in CLL. However, it applies to patients with mantle cell lymphoma as well. Our group did this work a couple of years ago, where we found that patients who had high comorbidity burden, as calculated by CIRS score, Cumulative Illness Risk Scale score, actually were more likely to discontinue therapy with Ibrutinib and had shorter overall survival. So this is retrospective real-world data. So it is important to look at the burden of comorbidities. And of course, in mantle cell lymphoma, often there are no other options, and still Ibrutinib may be a better choice than chemoimmunotherapy. Then there is risk of bleeding that I mentioned. Ibrutinib, and it's generally a class effect. In general, it is a class effect. Particularly with Ibrutinib, there is a combined inhibition of BTK and TEC, which blocks multiple pathways within platelet aggregation and adhesion, as shown here. There is again risk of atrial fibrillation. Like Dr. Lamanna mentioned, it appears that risk of atrial fibrillation is lower with second-generation agents, and as you have seen, it seems to be true in lymphomas as well, just like in CLL. Risk is particularly high in patients who have history of atrial fibrillation or who are older than 75, as is shown on this chart. And work from Ohio State group, cumulative incidence of hypertension on patients with Ibrutinib is also very high. So now, particularly in patients who have been on BTK inhibitors for a year and a half, I become very careful and I evaluate their blood pressure very carefully and introduce antihypertensive therapy when indicated. Then, of course, the next question is resistance mechanisms. And there was a question to Dr. Bird about this in CLL, and where BTK mutations, C481S, and PLC gamma mutations seem to account for the majority of resistant cases. Not so in mantle cell lymphoma, and there are different stories here. Yes, BTK mutations still occur in patients who progress on Ibrutinib or other BTK inhibitors. However, there is also primary resistance in mantle cell lymphoma. Patients with blastoid variant of MCL actually do not respond so well to BTK inhibitors, and it seems that in that case, activation of alternative pro-survival pathways confers resistance to BTK inhibition. Of those pathways, PI3K pathway and FKB pathway seem to be very important, and therefore combination strategies in those patients will need to be developed. Analysis of samples from AIM study, venetoclax, ibrutinib and combination, identified some novel mutations which are responsible for relapses in mantle cell lymphoma, and one of them is SMARCA4. This is a chromatin remodeling factor, so very novel, interesting finding. And one of the things that SMARCA4 does when mutated, indirectly, it seems to upregulate some anti-apoptotic BCL2 family members, for example, BCLX. So a much more diverse landscape of resistance in mantle cell lymphoma when it comes to BTK inhibitors compared to CLL. And finally, I'm a big believer in targeted therapy, and I do believe that treatment with BTK inhibitors will soon have a role in frontline mantle cell lymphoma. We do have a couple of studies at City of Hope National Medical Center, led by myself and my colleagues, which investigate BTK inhibition in this setting. Well, the problem is then, what do we do about BTK-resistant mantle cell lymphoma? Well, one approach would be venetoclax combinations. The emerging data of venetoclax single agent in ibrutinib-resistant MCL so far is somewhat underwhelming, with a response rate of roughly 50% and duration of response maybe 9-10 months. So far, single agent venetoclax, even though it provides some time to bridge to other therapies, is not a full answer. So combination therapies will be needed. Then there are novel targets, for example, ROR1, CDK9, and then immunotherapies. Bispecific antibodies are showing promise. And finally, cellular therapy. None of the talks these days in lymphoma is complete without mentioning CAR T cells. So I will choose this mention to close this talk. Anyway, thank you very much, and I'm happy to take questions.
So Dr. Danilov, again, that was a great lecture. Thank you very much. And I see a couple questions coming in. So the first question I see is, how do you see BTK inhibitors being used sequentially around CAR T cells in both mantle cell lymphoma, where they've shown a lot of efficacy, and CLL? Do you continue them? Do they help CAR T cells? You're at the CAR T cell center of the world, so I'm wondering if you could comment on that.
Right. So there is certainly enough preclinical evidence that suggests that combination of BTK inhibitors and CAR T cell therapy may lead to enhanced responses. And this is an area of very active investigations. And here at the City of Hope, we do have several studies which combine BTK inhibitors with CAR T cells in patients with CLL and in patients with other lymphomas. I think the jury is a little bit out on that still, how this is going to go. Certainly, we do see deep responses in those patients, and there have been publications to that effect already. However, to fully answer the question whether combination of BTK inhibitors and CAR T cells is superior to CAR T cell therapy alone, we will need some additional data before we know for sure.
Okay, and this one's a tough one. I'm glad you're getting this question and not me. So you have 3 BTK inhibitors. Say, who wins the beauty contest for your young patient and your older patient with comorbidities? What do you do in your practice?
Well, yeah, so I find that physicians are creatures of habit, and once we get used to certain things, we continue doing that. I have to say, with all the data that's emerging with novel second-generation BTK inhibitors, Acalabrutinib, Xanabrutinib, I participated in clinical trials with both agents. I also participated in clinical trials of Tirabrutinib, which is far less advanced than the other two. I would say that so far I'm very impressed with second-generation BTK inhibitors, and overall I would favor use of second-generation BTK inhibitors in most of my patients. And that is dictated by the fact that so far, even though there are very few direct comparisons, one I just mentioned, the ASPEN trial, but so far, overall, the majority of data suggest that there is less atrial fibrillation. Overall, those drugs seem to be subjectively better tolerated, and the efficacy so far as we know, is the same. So without endorsing any drug in particular, I would say that in my practice I have mostly moved to second-generation BTK inhibitors, both in patients with CLL and mantle cell lymphoma. Where ibrutinib has not been replaced is CNS lymphoma, of course, plus it does have several other indications.
Yeah. Okay, that's great. I think I see one other question, and probably all of us can toss in our answer. And the ASH has guidelines that came from experts, and so we have a CLL or a mantle cell lymphoma patient that needs to go on, first-line therapy. Let's say, we'll say CLL, because this person's asking about CLL. Are we picking a combination therapy with venetoclax, obinutuzumab, or a BTK inhibitor in the setting of COVID-19? And I'll start and say we debated this. I'm on one of the people on the guidelines, and we talked back and forth. I think most of us said a BTK inhibitor because you're not coming to the physician's office as much for the early monitoring. But I'm curious what the two of you think about this.
Yeah. I've discussed this with my colleagues as well. And so, so there's a couple of parts to that. One is definitely ease of administration during this time. So a lot less office practice use and being at the facility. So that's one benefit. And then, of course, with the venetoclax obinutuzumab, there's definitely can be more myelosuppression, certainly need for closer monitoring and blood count evaluation. And so certainly a little bit, there can be some more hiccups during the beginning. And so for all those reasons, and I guess the question John, I want to throw this back at you is, clearly we don't have a vaccine yet, but in the future, how will our patients mount antibody responses in the first place? And will certain therapies inhibit, vaccine administration, or I should say mounting of an immune response to a potential vaccine?
Yeah. I think we don't know the answer to that question. And, we need to be studying these populations in different ways now. Dr. Danilov, I'm just curious how you would manage that patient.
Yeah, so far on the West Coast, as you know, and here in California, we have been a little bit blessed. I don't want to jinx myself. So with fewer cases of COVID compared to the East Coast. So luckily for me, I actually have less experience than Dr. Lamana managing those patients. But I did have to start a few patients on therapy or recommend therapy as a second opinion. And I have to say that just like the two of you, I tend to lean towards BTK inhibitors as a frontline option for the reason that it does call for fewer visits, particularly in the first 6 to 8 months, fewer blood checks, and even though before COVID I was leaning to enhanced use of venetoclax obinutuzumab due to multiple considerations, during this COVID time it has become I have undergone a bit of a shift. In terms of vaccinations, I agree, it's a really interesting question, and we really don't know. There is experience. There was a publication concerning response to flu vaccine in patients who are on ibrutinib, and while they don't respond to the same effect that normal individuals, they actually do respond to vaccination. And there was data from Adrian Wisner's group with shingles vaccine, which actually did show the same, that they were able to detect immunologic response. So I believe that we'll see.
Every vaccine is going to be the same, and let's just all hope that we have a vaccine moving
Yes.
forward that we can test. So that was a great discussion. Now I'm just going to try to summarize some of the things that we talked about tonight. The first would be how we sequence BTK inhibitors into therapy. And clearly here, for young patients who are fit, we would consider two things. For patients who have IGVH mutated disease, in the initial therapy, we would give FCR based upon the possibility of cure, or obinutuzumab plus obinutuzumab plus or rituximab with ibrutinib or acalabrutinib. For the unmutated patients, it's pretty easy. Say you would do ibrutinib or acalabrutinib, and again, the role of CD20 antibodies is there's not clear data that they're beneficial, but probably in younger patients we would tend to use them. In older patients that are patients who are younger who are less fit, we would use a BTK inhibitor, probably not with a CD20 antibody. And then in relapse disease, the second generation drug, acalabrutinib, looks very promising, particularly if patients have a lot of comorbidities. Ibrutinib is also a very, very good choice. A lot of long-term data with it, maybe more side effects. When we move to mantle cell, as right now the data supports second-line therapy, and I think we heard Dr. Danilov say that he likes the second generations. I do as well, although it's a beauty contest, and hopefully we'll have an answer, not in this disease, but probably in CLL. In Waldenstrom's, most of us use ibrutinib right now, although there's data with both of the other second-generation BTK inhibitors. And in marginal zone lymphoma, we use ibrutinib as a second-line therapy after rituximab. And we didn't talk about this, but most of us, I think, would also consider idelalisib in this setting. It's a very good drug for that. When do we not use BTK inhibitors? I never give it with chemotherapy. I stay away from warfarin as well. The other inhibitors, the 10A inhibitors or thrombin inhibitors, may have similar risks. It's really not well studied. If I have to give anticoagulation and the patient has a high risk for atrial fibrillation and complications, I'll change therapies to venetoclax or idelalisib. If they're low risk, I sometimes will treat through with aspirin. And generally, I don't prophylax for fungal therapies or pneumocystis unless patients have been on steroids with BTK inhibitors. And although I tend to give Valtrex to try to prevent shingles. And finally, a very, very important point, if somebody's progressing, I line up my next therapy before I stop the BTK inhibitor because you can see a rip-roaring progression. There are selected recommendations that come from ASH. For CLL, if you don't need to treat patients, don't treat them. Patients should get short-acting therapies and avoid therapies that require frequent visits to the doctors. And I think you've heard us talk about our preference for BTK inhibitors in this setting. For indolent lymphomas, again, very similar, staying away from chemotherapy here, using antibodies, which are easy, and then considering going to subcutaneous antibodies, which patients can spend less time in the clinic, and then finally, really considering BTK inhibitors in settings where you're choosing between chemotherapy or the salvage chemotherapy because of the time in the doctor's office. Finally, I'd like to highlight that there are a number of BTK inhibitor studies treating patients with moderate to severe COVID-19. These studies are open around the United States and in Europe, and I would encourage you to put your patients on these studies. I list 3 here that are on clinicaltrials.gov. There will be others that are coming. And again, the science behind this is really exciting, and it's really neat that a drug that was developed initially for cancer might help treat diseases that are outside of the cancer. Finally, I want to thank my my fellow presenters tonight, Dr. Lamana and Dr. Danilov. Thank you and have a good day. And again, go out and do something really nice for somebody else today, and bring good to others in this difficult time our country finds ourselves in. Thank you very much.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/UVJ860. This activity is supported by an independent educational grant from AstraZeneca. This CME MOC activity is jointly provided by Medical Learning Institute Incorporated and PVI, Peerview Institute for Medical Education.